With every trial, every test, we move closer to the rest. A world where pain no longer stays illuminated by brighter days. Waits for a cure. Rise and shine, rise and shine.
So thank you everyone for inviting us to this pre-CROI workshop, community workshop. From somewhere very cold, I'm going to bring you to Thailand. So this is probably something that's going to be more appealing during this very cold weather. My name is Carlo. I'm from Search Research Foundation, and I work with an NGO that works with the U.S. military HIV research program in doing HIV cure research in acute HIV infections. So basically, how we say hello in Thailand is Sawadi Krap. So hello to everyone. I will not be talking about the prerequisites of why do we need a cure? How do we go there? I'll not be talking about how do we treat cure, like all the strategies to do it, because that's already been done. And that's already said very well by Dr. Nicolas Chamond in the previous talk. So what I'm going to discuss with you now is how cure research is done in a low middle income country in an Asian perspective. So that's probably a little bit more different from what you're used to here in the US or in Canada. And I'll go through how ATIs happened in our site and how it did evolve, and then focus on the current cure trials that we have in Thailand right now. So I am from a group of people who known as Search. We used to be in the Thai Red Cross AIDS Research Center, where we were known for, but now we are our own non-government organization, and we were started in 2005 together with the U.S. military HIV research program, the NIH, and the collaboration with the University of Hawaii and the Thai Red Cross. And in 2009, the NIH started the largest acute HIV cohort in the world. And this is to establish an acute cohort that is primed or that are early treated so that the reservoir size is low, but also have these participants involved into cure research or HIV remission trials. So it wasn't easy to start an HIV remission trial. From 2009, it took us almost 6 years to start our first cure trial. The first cure trial was RB409. That's with a latency reversal agent, a combination of vorinostat, hydroxychloroquine, or maraviroc, the WHM. Then RB411 is using early ART, and then RB397 used BNABs, RB405 used therapeutic vaccine, and RB398 also used BNABs in an early acute context. So these studies started in 2015, and like every 1 or 2 years, we started a new one. Just for the community part, I think this is important that at that time from 2015, we were very much institution-based. So it's all in the Thai Red Cross AIDS Research Center. But in 2021, we started to reach out into the communities, because that's when we realized that actually that's where we should focus on. And you can see here the community-based organizations that we worked with in Thailand. That's the PRIPTA Clinic, Tangerine. We also worked with the Pediatrics Adolescent and Young Adults Clinic, and SWING, which is a community-based organization which works with sex workers. Last year, we did the RV550, which looked at the IL-15 superagonist, and then last year in 2025, we started Deliver-01, which is the RV630 trial, which is a combination trial. So the difference between the blue boxes and the green boxes in these trials is that those blue boxes trials are actually like in the old style of doing HIV of treatment interruption. So in these studies, the treatment interruption was very short. It's only just 1 week. And then we started to, once we were more comfortable and once that we are already sure that it's actually safe, we moved on to like increase it so that we can see more how the virus evolves. So in RB550, it was 4 weeks, and RB630, the current trial, we are doing it treatment interruption of not the treatment, a viremia of 8 weeks. So these are the studies that are in the old style. So you can see here, RB411 used there's no other intervention except early diagnosis and early treatment, and then we stop ART. RB409 used a latency reversing agent, vorinostat, and then we stopped ART. RB397 used a broadly neutralizing antibody, but that's not during the time of ART. We stopped ART and then we gave the broadly neutralizing antibody during treatment interruption. RB405 used 2 therapeutic vaccines, AD26 and MVA. It's a prime boost combination, and then we stopped ART. And then the monitoring during treatment interruption was every 3 to 7 days. The resumption was 1,000 copies that is confirmed. So just 1,000 copies of viral load, you already restart the ART. And then the outcomes are all about safety, viral control, and then the maximum was like, and then looking at 24 weeks post-ATI for safety. So that's the older studies that we've run. The RB550 and RB630 are a little bit newer. RB550, I'm presenting this in Troy on Tuesday as a poster. So the results of this study, I'll be presenting next week. So this one used an IL-15 superagonist, which is injected and causes a big rash. And then once we saw the results in the reduction in the lymph node reservoir size, we thought, okay, maybe it could work. So what we did is after they did the preliminary injections, we went on to do a treatment interruption. And the current one that we're doing now is a monster of a protocol, which is the one that I will discuss more. This study is called RB630. It is the first study of the DELIVER initiative. DELIVER stands for Developing Leadership in Viral Eradication Research, which is the flagship program now of Cure Research for the military HIV research program. So you can see here the study design, the basic schema, but there are 7 investigational products in this study. And then there is also a temporary treatment interruption at the beginning, and then an analytic treatment interruption at the end to test if the intervention worked. And in this study, ART resumption criteria is viral load of 1,000 for 8 weeks. So it's, if you think about it, you will be viremic for 2 months, basically, before we restart you. The protocol share, so DELIVER 1, also known as ACHIEVE, approach to control HIV with immune enhancement and the vaccination, the safety and efficacy of broadly neutralizing antibodies combined with therapeutic vaccination for the induction of HIV remission. The protocol chair is Dr. Don Kobe, and the principal investigator is Dr. Kiat Roksangtam at the Chulalongkorn University in Bangkok. So what we hypothesize is that this combination of the broadly neutralizing antibody therapeutic vaccination will be safe and will elicit HIV-specific immune responses that may potentially kill infected cells and lead to a reduced viral load set point during analytic treatment interruption. The objectives are 2, which is basically safety and impact of these vaccines and broadly neutralizing antibody, and the primary endpoints are the grade 3 adverse events or serious adverse events and the viral set point. And if you look at the protocol, there is a very long list of secondary and exploratory objectives, but it all revolves around the immune responses, the viral rebound characteristics, and then the viral reservoir. So this is the full study schema of the current study. So it is a lot. So let me walk you through it. And then also it would help if you think of yourself as a participant and see if this is something that is appealing to you. So the study has 2 primary arms, 1 active arm and 1 comparator arm. Both has 20 participants. And the inclusion criteria are listed here. You have to be 18 to 60 years old. You have to be diagnosed at acute HIV infection and then started ART quickly. You have to be on integrase inhibitors for more than 48 weeks with viral suppression, CD4 count 400, no Hep B, no Hep C, virus sensitive to the BNAb, and then HLA-B 57 negative, which is a protective allele. So if you suppress, we know that it's not because of the drugs, it's because you have the allele. There are 4 steps, namely step 1, 2, 3, and 4. And it starts with a TTI, or a temporary treatment interruption. What will happen here is that there will be an 8-week period that we will want your virus to rebound at a certain level, which is 1,000. And the reason for that is we need that virus to be present so that the BNAb can attach to it and then see the cell so that it can destroy the infected cells. So that's the reason for the TTI. So it's a maximum of 8 weeks. And if you rebound, you will go to the next step, the step 2. If you had a decrease in CD4 or clinical symptoms, you will restart ART right away. And then we will send you to the RB412 protocol, which is another safety follow-up protocol. That's nothing is done there. It's just to monitor your safety. And then if you did not rebound at 8 weeks, you will go to RB412. That's the safety protocol again. And then we will offer you to stay out of ART, or if you want to restart, you can restart and then monitor you for about a year. Step 2 is the part where we give all the investigational products. And as you can see here, it lasts to around 22 weeks or about 6 months. And these are the 7 products. We have 2 broadly neutralizing antibody, VRC07 and PGDM1 400. We have 4 vaccines, Shadox C1, C62, M4, MBA-M4, A244, and then an adjuvant ALF-Q. And then we will give you another the 2 broadly neutralizing antibody before we stop the ART. For the comparator arm, you will receive the BNAbs, but you will be randomized if you will receive the vaccines or the placebo. So in this study, you will receive something. It's not a complete placebo. So this is how it looks like. This is the VRC07 from the vaccine research from the NIH. And it's in very small vials, 2.5 ml. And you take it out of the freezer. You have to thaw it and then put it into the syringes. And that's how it's done. And then you put it in the bottle so that it can be infused to the participant. And you note that this BNAbs, it takes a long time. So participation in these trials takes very good commitment from the participants, because these BNAbs, you have to infuse in 45 minutes, flush it, and then give you 1 hour of observation time, and then do it again, because for the second BNAb. So that just for the BNAb infusion part, it's like 6 hours that you have to stay in the clinic. This is an example of the vaccine. So you can see here the vaccine is covered because we need to be blinded. So that's the vaccine itself. The nurses are instructed not to aspirate. You have to just inject it and push, because if you aspirate, you will see the contents, so you're not blinded anymore. So just to show like how the experience of the participant will go through, and also of the study team. So once you've got all the 7 investigational products or placebo, we will start ATI, or analytic treatment interruption. But at the beginning, you will get the last BNAb. That will last for 50 weeks if you don't rebound. And you cannot enter the ATI part if you haven't received all the study products. Your viral load needs to be less than 50 and no virologic failure in step 2. Your CD4 count has to be 400. You cannot have new Hep B or Hep C infections during the time of ATI. That's for just for the safety part for the participants. Step 4 is when you restart. So if the virus rebounded, if the virus rebounded, you will restart your ART at 1,000 copies times 8 weeks or 100,000 copies times 2. So just a confirm 100,000. If your CD4 count went down to less than 350 or 14%, you will restart your ART. If you have antiretroviral syndrome or clinical HIV progression, if you got pregnant, or if you request it, we will also restart the ART. This study is already complicated, but it got further complicated with the exploratory arm. The exploratory arm has the same inclusion criteria that I've discussed before with the primary arms, but it starts at the time of infection. So participants who just got infected in acute HIV will be offered to join this trial and then started right away with the BNAB, and then continue on with the step 2, 3, and 4 that I've discussed earlier. So where are we now? We have screened, out of the 40, we have screened 24 participants and 20 have enrolled into the trial, so we're halfway. One participant did not rebound in 8 weeks. So that was nice, but then he went on to RV for the safety follow-up protocol and opted not to start ART, but after 2 weeks, he rebounded. So that was sad. But now he's already undetectable. Out of the 20, 15 participants are currently in the IP administration phase. And the first participant will start ATI in the last week of March. For the exploratory arm, we already screened 8 participants. 6 participants are already enrolled, so that's very fast because we just started in September. The 2 participants who did not fit into the criteria had a pulmonary infection and had an active Hep C, so they cannot go into the trial. And 6 participants are currently in the IP administration phase or step 2. And the first participant will start the ATI in April. So this is just the summary of the whole cohort. And we go to demographics. So the group 1 and 2 has all males. And then most of our participants are in the 30s. And these are the phoebic stages. So how acute are they? Most of them are in phoebic 2 and 3s. But this will make you happy. We had our first female participant in our trial. So this is the first participant. This is the first female who joined in any of the ATI trials in Thailand. So that was like very meaningful for us. And I was like very happy to have someone to like join into this cure journey. The age of these participants in the exploratory arm are very young, so around 18 to 19, and they are in phoebic 2 and phoebic 3. This is a very busy and complicated slide, but let me walk you through it. You need to look into the first 2 rows, the PGDM1400 IC80 and VRC07 IC80. That's the inhibitory concentration, or how effective are the BNABs tested to the time of acute HIV infection. So the redder it is, the darker the color, the more effective the BNAB is. And you can see here 5 panels. So you can see here these numbers here, these are the 5 groups. So that's priority 1, 2, 3, 4, and 5. So these are the groups that are more effective, effective to 1 BNAB, the PGDM. This is effective to VRC07. These are not as effective. This is like, it maybe not work. So what we're trying to do is to make the participants, to get the participant that has the best chance of cure, to enroll them first. So what we've done is to look at the prioritization and then enroll the priorities number 1, 2, and 3. So these ones, but it is not enough. So we didn't have enough consent, so we had to move into priority 4. We also have budget cuts. This study had all of the reservoir tissue sampling collection, gut biopsy, lymph node biopsy, MRIs, but leukapheresis, but we cannot afford anymore to offer that. So what happened is that we can only offer lumbar puncture. So we're going to do it after the BNAB, the first BNAB, so that we can see if the antibody penetrates the brain, and then at the time of ART resumption. So when you are at the peak of your virus, so and that's to see if the virus is present also in the brain. And there is exceptional participation into the LP. Out of the 20 in group 1 and 2, we have 17 participants have joined in the study in the LP, and then in group 3, only one said no. So that's very kind of them. These participants in the acute mother protocol, some of these participants did not join the LP, but then in this cure study, they joined the LP, so they changed their minds. And the reason I asked one participant is that, why did you change your mind? So he answered, because you asked for it, because you need it and it will improve the science, then I'm going to do it. So in terms of like implementing these studies, it's always good to just like explain it and then say to these participants, this is what we could do to move the science forward. This is an example of how it goes. It's not very scary. It can be fun, so people can be more comfortable with it. This is one of the one of the objectives of the protocol is safety. So we've had two serious adverse events. One is from the LP, so it's not related to the investigational product. I did it. And then the grade 4 neutropenia, this is one of your white blood cells went down. So at this stage, there was no symptoms. It's just like a lab finding. But the BNAB actually causes the neutropenia. But also the ART causes neutropenia. So we said that we cannot say really if it's the BNAB or the ART. So we said it's possibly related to the investigational product. We also monitor for the safety of the participants. So we give them a diary card that they have to answer for 7 days after they are given the BNAB or the injection. And you can see here that the local reactogenicity is quite good. It's just all mild. So this is most common are injection site pain, swelling, redness, and it's not so bad. So it's just something that you get from like a COVID vaccine. And the systemic ones are a little bit higher. They are more on the moderate grade 2, and the most common are rash, chills, fatigue, headache, muscle pain. So also similar to when you get like a vaccination when you don't feel well. So far it's been good with the IPs. Further, for the safety, we have like protocol safety review teams that monitors it and meets every week. And we also have an external group that reviews everything, which is called the Safety Monitoring Committee. And they meet like almost every 6 months and reviews the data. This is how we try to improve the Q research in Thailand. In the previous Q researches in Thailand, most participants gets very stressed about seeing their viral load go up. And when the participants are stressed, the nurses are stressed, the doctors are stressed, everyone's stressed. So and then participants would say that, oh, I want to restart. And that's good because they have that right. But I think we should have a way to offer to the participants to support them throughout this cure journey. So what we did is we had an integrated mental health component in the study. So you can see here, we have a certified cognitive behavioral therapist who the participants can see. This is optional. It's not mandatory. Participants are offered if they want to see the therapist during these time points in the trial. And everyone said yes. So, and And for the doctors, we don't know what they talk about in the trials, in the CBT therapy. So the only thing that we will know is that if there is potential for self-harm, that's the only thing that we will know from the therapist. But other than that, that they have their own things to discuss there. So this is how it looks like. It could be done online or on site. Sometimes because the broadly neutralizing antibodies takes a long time. So during the observation period, they're already doing the therapy at that time. So our next steps are to complete the enrollment for both the primary and exploratory arms. These studies for cure are phase 1, 2, they're very small. So if you don't fully enroll, the power to compute for statistical analysis goes down. So it's important to enroll as full as possible. We want to maintain the monitoring for participant safety. So far, it's been good. You've seen the results of the reactogenicity and the SAEs, and we have not had any major deviation so far. And then we want to continue the participant support, which is the most important for this. There is an abstract on Tuesday that looks into the TTI part, the first step, and how safe it is and how the virus evolves during that time. So you could look into the poster abstract 427 on Tuesday. And that's where I'd like to end with all of it takes a village to do these very small trials. It's a lot, but most importantly to the participants who trusted us and joined into this study. Thank you.
Yeah.
Hold on to that.
Well, that should be working.
If you can repeat the question.
Yes.
A slightly more enthusiastic round of applause, because I was.
Is there a component in the study to do PK analysis during the ATI to ensure that they're not taking their antiviral therapy? And if so, you get the results in real time, because that person has to leave this. That person would have to leave the study or be taken out later from the analysis.
So right now the budget is so the question is about PK or testing if there is intake of ARV during the analytic treatment interruption phase. So right now there is a provision in the protocol to test for it, but we are not going to test. We are going to batch samples everything for the analysis. It's not going to be tested while in the ATI.
Not real time.
Not real time.
But then if they were taking their ARV, you have to take out the whole account.
But the thing is that if they rebound, that means they rebounded, right? So if they didn't rebound, that's the time that you want to see, are you really? So we were not testing for everything.
It's just important that's components in the study.
Yes, it's in there, and there are stored samples that we could go to check if you really are ART free.
Check this.
I might not see.
Thank you. Thank you for your presentation. It's great. Have you all considered increasing the participation age rate over 60 for those who may be interested?
So the question is about increasing the age rate at 60. So that's more of a safety feature. So these are very, very new drugs. So if you have like more comorbidities, it would be affecting your health. So it's more for the participants' health at this point. But we had a CAB member who actually said the same thing. So we know that that's something that, but we had to cut at a limit. We had to put a limit for these for safe.
And so for future studies, do you plan to extend that? What was the scientific rationale
For the age?
Yes.
So there's no clear-cut scientific rationale. It's just like we just want to limit the comorbidities because some of these agents has an effect on the heart. So we don't want someone who has like hypertension or had like to be exposed to this kind of risk.
So I'm really very glad that you mentioned the psychological support. Because I feel I'm very often in this advisory boards for companies, and I feel very lonely to bring that point. So I'm very glad you do that, and I think both with the community and with medical doctors that have experience in sleep interruptions, where we see that there is a big need. I see that there is a big need, and I always get the answer. I think you should try to screen with people upfront, but you cannot do that because you cannot predict how someone will react upon a treatment interruption. And someone's viral load might go from 2,000 today, 1 million next week, and that the psychological reaction to that is unpredictable for all of us, also for the people that participate. So I'm a strong advocate for having psychological support through the studies for all the participants, and I think that's a message that we should bring all together and to be benefits.
Yeah. So the comment is about integrating a mental health support into the trials. So thank you, Linus.
Follow-up question for that. So you mentioned, and rightly so, that you don't, everything they said in their CBT sessions were confidential. But I think it'd be really helpful for the study team to know what issues people were grappling with. Were you doing at the same time any kind of survey or anything to get that information from the study participants?
So it wasn't, we didn't think of it that way.
Okay.
If we had to get data, it needed to be in the protocol.
Right.
So that's something that we could work on. I'm not sure if we could work on it retrospectively with the notes of the CBT therapist. That's one way to do it. But right now, it's really just the focus on the mental health of participants, not getting but we will have PHQ-9 and HADS during these events. So we will just have that objective data, not qualitative data.
Yeah. Would it be possible to do a survey afterwards? And if not in this study, then build it into future studies? Because it's really important to know what those issues are. It'll help you design future studies.
Yes, that's, yeah.
We have some questions or some comments.
Over here. It's on the topic of.
Because I feel really need like make a survey for the time like in that car in describing that whether the people don't what is their like experience feeling like their experience participating in science. So it's a procedure that most studies have, there seems like at least having some formal.
Saying that maybe you don't need to do something so formal as a survey, right?
It is possible. We could also add it into the clinical notes so that it's at least documented. But I think if you present something, if you're gathering data, there should be like some language at least into the protocol. But if we amend it, it's something that we could add.
Thinking that 61 and young could be really old and sometimes that could affect patient. Is there a way you have empowered caretakers or engage them in any way to feel they will be able to go through this procedure as well as inside the place that emotions are like?
Here.
61 years old.
She said, because participants are older, is there a way that you engage their caregivers in order to be able to assist them throughout the process? Or their loved ones?
Yeah, so the question is about those who are 61 years old and above, the engagement of the caretakers so that they can be involved into the study. One, the cutoff is 60, so they cannot be in the study. But for those participants who are interested in the and outside of the age range, what we do is we try to explain that this is a safety feature of the protocol. And if there is another study, and if it works, then we could maybe expand to the age range to like a higher age.
Oh. So my follow-up question, I guess I didn't understand. Say you're going to have involved caregivers for people over 65?
She said that.
Okay, yeah. Oh, okay, because I mean, yeah, a lot of us are above over 50. Yeah. So that's the question, is whether or not there is involvement in both. Oh, okay.
And we do have one question online. I'll stop it and read it. So Elizabeth asked, with trials exploring BNABs, therapeutic vaccines, and other interventions, do you see remission being achievable through a single strategy, or is the future more likely in combination approaches?
Yeah, so we had 2 broadly neutralizing antibody studies in this cohort, and it did not work. So it's almost like ARVs. When we had the ARVs, we started with 1, with 2, and now we have triple therapy. So the concept is the same. So maybe if we have like some signals from BNABs and then some from the vaccines, maybe if we combine it, it will be stronger. That's the approach that we're taking. But a single active study is probably not going to work.
Quest for a cure, rise and shine.